My clinical practice is mostly dealing with patients with chronic myeloid neoplasms, and that include everything, but also acute myeloid leukemia. But my subspecialty of interest is myeloproliferative neoplasms. So I see a lot of patients with essential thrombocythemia, with polycythemia vera, with myelofibrosis. And most of the patients are low risk. Low risk patients with ET, low risk patients with PV. Basically what this means is that these patients have not experienced a thrombotic complication. And that's pretty much what low risk is. And sometimes we would like the patients to be younger than age 60, for example, and have no history of thrombosis to say that they are low risk. But now with all the mutations that are available and our ability to associate some of these mutations with risk of blood clots, we can also identify in this traditionally low-risk patients who are young and without a history of thrombosis, whether or not they are at a particular risk of having thrombosis. For example, those with a JAK2 mutations might be at a higher risk, and those with a type 2 CALR mutation could be at a lower risk. The triple negative could be a lower risk. In PV patients, young patients that do not have a history of thrombosis are considered to be low risk. So these are all low risk patients, and there's a lot of them. And the question, the most important thing in managing these patients is to remember not to kill the patients before the disease kills them, because these patients live forever. The average expectancy in young patients, age below 50, for example, is over 30 years. So these patients can live for 30 years. So it's very important to make sure that what we give them is not going to shorten their life. It is impossible, and nobody has shown that you can actually prolong survival in low-risk patients with ET or PV. It's already prolonged for you. The important thing is not to shorten it. As such, as much as I can, I try not to use cytoreductive therapy in these patients. So the question is, how actively do I consider initiating treatment for these patients? Not a lot. I actually, whenever I see these patients, I say, okay, how can I not give them drugs? That's my intention, is no drugs. No drugs is always good than drugs. So most of these patients can be managed with simply aspirin, and if they have PV, with phlebotomy. And the only time I consider cytoreductive therapy is if they have symptoms. Now remember, these are low-risk patients, so it's not about thrombosis. I'm not treating thrombosis here. If they have symptoms that they cannot tolerate. Some patients have, discomfort because of an enlarging spleen. Some patients have very bad pruritus, which is itching, especially after they take a shower. Some patients have constitutional symptoms. Some patients have symptoms from the disease that require treatment beyond aspirin. So that doesn't happen a lot. And when that happens, individually, I sit down with the patient and tell them the drugs we have this side effect, this side effects. Which one do you prefer? Do you prefer to live with your symptoms from your low-risk disease? Or do you want me to give you drugs to help you with that, but the drugs come with side effects, and let the patient decide? Now, the other question is there any threshold? Because the platelet count might be 1 million, 2 million. Is there any threshold? And I think there it's all about platelets, because everybody will have to go through phlebotomy if they have PV to keep the hematocrit below 45. Here the question is the platelet threshold or the white count threshold. For me, there is no threshold. It's the patient's symptoms that is the threshold for me. So you say, well, how about 1 million? No. 2 million? No. In fact, the platelet millionaires, the patients who have a lot of platelets, actually have a lower risk of blood clots. So the important thing there is if they were in aspirin, they might have an increased risk of bleeding, so I have to manage that properly. And there are some laboratory tests that we can do. So in general, there is no threshold for me to decide, oh, this patient is platelets 1.5 million, now I give chemotherapy. No threshold, symptoms. The ultimate purpose of treating patients with low-risk ET or PV is not to kill them before the disease kills them. Whatever drug you give them, nothing might happen in the next 5 years, but something bad could happen 30 years along the line. You have to remember these patients are long-lived, so you have to remember what's going to happen when they're 60. If there's a 20-year-old or a 30-year-old or 40-year-old lady or man, you have to think, what could happen when they are 60? Could I have caused an increased risk of leukemia or skin cancer or chronic immunosuppression? You have to remember. So the ultimate purpose is to be conservative. Now, if they have symptoms, obviously you treat the symptoms, but outside of that, in low-risk ET or PV, you don't have to prophylactically treat them to prevent thrombosis because they are low risk. So very conservative, no drugs if you can afford it, but otherwise maybe aspirin once a day or twice a day. Here, my choice is, should I give aspirin once a day or twice a day? Not if I have to give chemotherapy. The disease myelofibrosis is different. And by the way, in terms of ET, what we've talked earlier, there are a number of issues that I haven't mentioned, and that is, there are certain circumstances, like if the patient is pregnant, if the patient has, let's say, surgery, needs surgery, and these are low-risk ET or PV patients. If they have that situation, you might need to manage them differently. Now, I have just published an article on JAMA, on ET, and you can find it if you just go to JAMA and essential thrombocythemia. There is a podcast over there where I discuss how you manage the pregnant patient, how you manage the patient during surgery. Those are very, very important. So you could just go to JAMA and with the podcast, and the paper itself goes into details as to how to manage. But the concept remains that if they are low risk, try not to give them drugs. If there is a pregnant patient, aspirin might be enough. If the surgical patient, you go along with the surgical protocol, but make sure that they go in with a platelet count below 600 and the hematocrit is very well controlled. Now, myelofibrosis is a completely different drug, different disease. It is as bad as, let's say, myelodysplastic syndrome. It's no longer a nice myeloproliferation. It's no longer as nice as PV or ET. Here, the problem is you have a very shortened life. I mean, on average, 5 years expectation. And then the quality of life is really, really bad. And there are 3 things which affect the quality of life. It's a big spleen you have, and the liver can also get big sometimes. Constitutional symptoms, you lose muscle mass, and then you become very anemic. Most of the patients get into transfusions. So there's a lot of drugs out there. Now, because these drugs are simply inadequate, they do not prolong life. They do not change the natural history of the disease. There are many, many new drugs trying to achieve that. And as you know, whenever you have a chronic disease where you can't cure, a lot of drug companies want to make sure that you get into the market and buy their drugs so that you can use it. So there's many, many drugs. There is no shortage of drugs. The problem here is When you see a patient with myelofibrosis, there isn't really a lot of choice in terms of available drugs. There are drugs you can use for anemia and you can shrink the spleen perhaps, but it doesn't last for long. And obviously these drugs have value because they improve quality of life. But if your objective is to cure the patient or prolong the life expectancy, the only thing that can do is stem cell transplant. Therefore, if your objective is to cure your patient or to make your patient live longer, if that is the objective, the only way you can do that is through stem cell transplant, at least now. Hopefully there will be drugs that will change my mind, but for now it's that. Therefore, you cannot be distracted to go to, oh, maybe I should use this new JAK inhibitor, or maybe I should put my patient in this new clinical trial. Because none of the clinical trial drugs right now are that exciting. They're there, they work like everything else, but they don't really prolong life. Nobody has shown that that would be the case. Therefore, in my practice, I don't get distracted. I always see a patient, what's my primary objective? Prolong life, transplant. I work with the transplant team and we try thinking transplant. What can we give before transplant? You can give some of the drugs to help facilitate the transplant process. And then after transplant, how do we deal if the patient relapses? What kind of drugs can we give to prevent bad complications from transplant, like graft versus host disease? So that's what I am thinking on. All the novel drugs that are being developed at this point are not that exciting for me to say, you know what, maybe you should go to this clinical trial. I would rather take my patient to transplant. Now, if the patients cannot be transplanted for one reason or another, then it is reasonable to consider the novel drugs. But when you consider the novel drugs, don't be cajoled into just doing that just because there is a clinical trial. You have to think of yourself. If it is you and there's just another drug and you know that it's not going to work, why would you want to put your patient on that clinical trial if you're not going to put yourself in there? Some of the clinical trials are simply there to develop the drugs, to help the drug companies advance their drugs. So you have to first look at the patient rather than the protocol. When the patient comes in, you look at the patient, what's best for the patient, not whether or not your patient fits that protocol. So it's very, very important. There are a lot of many novel drugs. None of them are exciting. I hope they become exciting as time goes by. But for right now, I cannot be distracted. It's going to be transplant all the way. I've never been to South Korea, and this is my first time. I was really impressed by how disciplined everything is. The people are very courteous, they're hospitable, and many of them speak English, which really helps. Obviously, South Korea is an advanced country, and that is reflected on this beautiful skyline. But more than that, there's a lot of character. There are the seas, there's a waterfront, and there's a lot of things to do once you're in Korea. So it's a matter of weighing how much I have to stay in the meeting versus how much I want to go sightseeing. But I think since I have about 3 days here, I'm able to fit most of those. The sessions are all very well done, very well structured, and I think there is no particular session per se or topic, because this is an opportunity to widen our horizons as specialists, to look into different disciplines. So I just choose topics that catch my eye, Sometimes it's the speakers, sometimes it's the topic. So there was no specific sessions I had in mind. I just wanted to look at the overall program and choose as they come. As far as young researchers and clinicians in Korea, I have the same message for them as I do for young researchers anywhere. And it is to remind them that they have been blessed with the opportunity to help patients. That is the main message I want to give them, is that they should celebrate this opportunity, that they are going to make a living out of helping others. And I want to remind them how beautiful patients are. For them, you are God. For them, you are everything. You have unconditional love from patients. You are blessed with that. Always remember that your best friend in your life, other than your family, is going to be your patients. So remember, you are very blessed, and be very proud that you are a physician, a clinical researcher, which is trying to make a difference in patients' lives.